morning, Professor Tony Rudd. Tony, thank you for making the time to come to this, and I could see you sitting there throughout the session. So I'm sure you're aware of the brief we've taken on here and what we're trying to do, and we're obviously delighted to have you, someone who was one of the principal champions of change following the London Framework for Action in a fairly controversial area, which created a lot of noise, but despite the noise, you made the change with you and your team, and so we're delighted you're here, and we have a number of questions to ask you. How could we change you from being a stroke physician to maybe being I'm not going to use because people automatically will say that's something wrong with that service, so will hold from saying anything else. So please tell us what your thoughts are, and then you do know who my colleagues are here, and then we'll spend a few minutes asking you questions. To Tony.
Well, thank you very much indeed for asking me to come and speak. And I will talk, obviously, from the perspective of my experience with stroke. But stroke is an archetypal long-term condition, and I think that many of the lessons that we've learned from stroke and many of the lessons that we still need to learn will be applicable to lots of other conditions as well. And I want to start by saying that I really firmly believe that the NHS in London is not broken. It doesn't need complete restructuring again, but I do think that there are certain things that are needed, that radical change, that are going to be able to deliver increased quality across the board with the financial constraints, obviously, that we are all going to be facing over the next few years. I think it is worth reflecting on the lessons that we've learned from stroke. We started with a condition that clearly was not being well treated. There were major failings in many of the hospitals and in the community in terms of the quality and the quantity of care being delivered. We were starting from a base where we knew that the way that stroke care was organised had a major impact on outcomes. So we had a good evidence base telling us how we should be delivering care, both from research trials but also from experience elsewhere in the world. And one of the key lessons from stroke, or key messages, was that specialism worked. And that if patients with stroke were managed in units with expert nurses, with expert doctors and therapists, and then transferred back out into the community for a further period often of expert specialist care, the outcomes, both in terms of long-term morbidity, but also in terms of mortality, in terms of patient experience, were significantly better. And I think that's an important lesson that maybe we come back to in questions, really, in terms of the push now from the Future Hospital Commission and others to have greater generalism. I have real concerns that although you may be able to spread specialist doctors around a hospital wherever the patient might be, I think it's much more difficult to spread specialists and expert nurses, particularly the band 5s, band 6s, who actually end up delivering most of the care, coming back to some of the things that were said by the previous witnesses. Stroke care, the most publicised bit of the reconfiguration of stroke care has been around the hyperacute care, but it's very important to realise that the whole of the pathway was looked at and has undergone change, some to a greater extent than others, particularly in the rest of the inpatient hospital rehabilitation and care, the community care and the longer term care. And there's no way that you could have reformed one bit of that pathway without looking at the rest of it, unless the back door was opened wider than it was in terms of moving patients through the system. We would have, I think, failed in what we did. So it has been a big success, but I don't think we should be uncritical, and I think there are still very important lessons to learn. Stroke reconfiguration in London was delivered because, for a number of reasons, we had the overwhelming support of the clinical community that something needed to be done. We had very strong leadership from the Strategic Health Authority and the Joint Commission for Primary Care Trusts, and from individuals, not least yourself, Ara, but also Ruth Carnell and Cyril Chandler and Andy Mitchell and so on, to make sure that actually what we did, we designed, what we discussed would actually be put through in the face of opposition a little bit of opposition from the public, but greater opposition from some of the provider units. We had an evidence base on which to sell the change to the public, and I think that comes back to the discussion earlier on today about making the case to the public. We also had at the time the stroke and cardiac networks, who were very well resourced to help deliver the operation, to actually get involved not just in strategy, which is obviously where the networks are predominantly cited now, but actually to be providing day-to-day assistance in implementing a major reconfiguration. We had stringent standards, we had inspections, so there was an element of sort of top-down control. And we had, perhaps most importantly, financial incentives to deliver higher quality care, money that was put into delivering an extra 400 nurses in London working in stroke care, an extra 100 therapists. And what we also had developing at the same time, which I think is again important from the point of view of more general care, is that we had an audit system which was able to measure the quality of care for the patient across the whole pathway. There are problems with the system. There is very little flexibility within it, and we're seeing major strains just at the moment, this current winter, in terms of beds. There is clearly some areas of the capital have failed to deliver, particularly on the further down in the pathway, the community care. There are still some areas which don't have specialist early supported discharge or adequate community rehabilitation to continue the care for people. There is, I think, some impact which has been inevitable in terms of the loss of the networks. And there has been, because of the extra pressures within the whole system across London, particularly inpatients but outpatient as well, there have been some attempts to try and water down the system to try and sort of accommodate some of the pressures from elsewhere. We've got some problems with junior medical staff. I think we need to look at the way that we train our junior staff. Instead of having people following curriculums that were historically considered to be the most important things to do, we should be starting to look at what the needs of the health service are and ensuring that our junior doctors are trained in those aspects of care. And I just use one example, that there is a lot of pressure from neurology, for example, for their SPRs, who are in some hospitals providing a huge amount of support for stroke care, but it is perceived by some of their seniors that this is having a very detrimental impact on some of the rest of their training. And so that is a circle that needs to be resolved or completed. The final thing that I think is a major problem that I perhaps wasn't aware of before was the quite large use of bed-based intermediate care for stroke, and obviously that is also used for many other areas of healthcare. It's a non-evidence-based way of delivering care. You go into these places, they're often staffed by extremely conscientious nurses and therapists, but actually the pressure on the system within that rather closed box, separated off pretty much from the rest of the health system, is that things move very slowly, decisions are slow to make, and I don't think it adds anything very much. So I would be pushing very hard to have a health system which provides you with your acute care, and when you've finished your acute care, which includes an element of rehabilitation, clearly, you then go back out into the community and have your continuing care provided there, rather than putting them into an extra box, which I think introduces great inefficiencies. I think it's a myth to believe that if you simply increase the bed pool in that way, you'll increase the number of patients who the system can deal with. So I think there are a number of developments that are needed. I think we clearly need to be shifting some resources from hospital care to intermediate care, to community care, I should say, and to cut down the bed-based care. And I think there are huge savings that could be made from closing some of those units. I think we need to remove a lot of the bureaucracy involved in discharging or transferring care from hospital to home. I heard the other day that in one unit they're taking up to a month to complete all the paperwork to get somebody to have a complex package of care in the community or going into a nursing home. That is totally unnecessary. A lot of the paperwork, clearly we don't want people to be going into nursing homes unnecessarily, and we need to ensure that the funding is there, but it's a terrible waste of time and waste of money and resource to keep people in hospital while those things are being done. While we have all these different silos between secondary care, primary care, social care and the rest in terms of financial silos, I think that is going to lead to inefficiencies. And I would want to see a radical change really in terms of the way that the budget for individuals is used, so that we are not in competition with each other. We're not facing a situation where a cash-strapped social services department are being very slow to take people onto into their services to save themselves money. I think that, as I've said, there are other conditions where we could spread that hub-and-spoke model for stroke, and that includes things like acute kidney injury. It includes some of the more generic neurorehabilitation, heart failure. A lot of the surgical specialties, I'm sure, would benefit from that sort of system. And I think I will leave my comments there.
Thank you very much for that. Thank you. Any questions?
Can I just, just addressing the post-hospital care pathway and the pathways for prevention of recurrence, the elimination of risk factors, etc. What in your experience are the factors that contribute to success in that domain?
I think it's around integration of care, knowing where the responsibility for that patient's care lies, and I think we fail very often in that, where patients are their care is transferred to the community in terms of the patient moving into their own home, but no one is quite sure who is then going to take responsibility for the ongoing care, and I'm quite convinced that that should be predominantly within primary care, but with some specialist access. And I think the other issues you raised earlier on yourself was around the IT. I think if we had a system where the patient held their own records, for example, that would make things very considerably better and put the patient much better into control of their own pathway. One of the huge issues in lots of long-term conditions is that there is this huge divide between hospital and community. The community services are often extremely complex in their structure, and in Lambeth, before we undertook a major modernisation project around stroke, there was something like 28 different queues the patient could join when they left hospital, and we didn't know where patients would best go. How could the patient possibly know? And therefore, the system was inefficient. We've changed that, but it's still the system around many parts of London that it remains complex, unnecessarily so.
Okay. Yes, Andy.
Tony, I mean, the stroke story is a great one, and I think you deserve great credit for having taken it as far as you have. I think there are issues, though, because, as you've alluded to, perhaps it's not quite as good as it could be, and the latest sign-up data suggests that, particularly with regard to community services, we're not performing well. Now, I want to explore with you the reasons behind that, because the stroke networks have actually previously had quite an important role to play, but the nature of the networks has changed. So is this a matter of the networks having taken their eye off the ball in terms of performance management, or is it an issue genuinely around resource and resource availability? But we do have to, it's not all as rosy in the garden as it appears to be at first glance. So how should we be addressing those issues, both in terms of oversight and the awareness that more resources actually needed?
Okay. I would be the first to agree that things are not as good as they could be. I am going to use the traditional riposte of the data are difficult to interpret. Having split the hyperacute care from the stroke unit care has led to some distortions in terms of the sorts of patients who go into the stroke units directly, the smaller numbers, the nature of those patients, making it very much more difficult to deliver the ideal model of care. These are patients by definition who present late, who often present atypically. And therefore the data that you're referring to, I think, needs to be treated with a degree of caution and understanding of the fact that actually you can't directly compare different systems where you fragment the care into different bits. Having said that, I do think that there are aspects of care where we have taken our eye off the ball. I think that the failure to be able to maintain that sort of day-to-day involvement from the networks has been a problem. We've reduced the number, because of simply resource issues, the number of times we go around and inspect and meet with all the staff in all the units. And I think that the community services, in terms of developing specialist care in the community, have never had quite that incentive to change, because of the funding, predominantly the additional funding went into the hyperacute aspects of care. And the reconfiguration of care with a whole new team of people commissioning care, moving from the PCTs to the CCGs, has also led to a hiatus, really, in terms of some of the developments that were needed.
And you also alluded to the need for greater integration, and we had talked about accountable care organisations in the previous session. I mean, would you see stroke, if we actually had a different model, say, where stroke patients served as a population, the funding was sort of linked to that particular group across the board, across agencies, whereby you had an organisation having responsibility for delivering those outcomes. Do you think that's something that could work well with stroke? It's a change in direction and a change of model, but I think you're suggesting that that might be a positive way forward.
I think it is. I think I'm looking forward to seeing the results of the pilot exercise around the year of care work, which I think is similar to what you're sort of suggesting. I absolutely believe that we need to be able to break down those sort of financial barriers to enable people to start using the money that we have got much more creatively. There is one other point which doesn't directly refer to what you've asked, but I think is something I wanted to make, which was around the fact that London did invest a significant extra amount of money, £21 million a year, into stroke. But that investment has actually ended up resulting in savings. And so I think targeting, making sure that you're providing the best quality care, particularly at the point of the illness where actually you can transform the way that patient is going to be for the future, is something which you may need to be putting extra money in parts of the system in order to be able to save money further down the line.
Thank you. May I have a couple of questions? One of which, maybe you can write to me about this, is the designation of the hyperacute centres. And we went through that process about 3 or 4 years ago. Do you feel that London should look at that designation and redesignate? In other words, create at least a driver of competition and driving the quality. Should we do that? Is that something that is in the...
I don't see any reason for doing that at the moment. I think that I'm happy that the quality is being maintained. Okay. However, I think actually for the stroke units...
You may do that.
I think that's something we need to do. I think there are too many small units.
Okay, wonderful. The second question is more of a personal question, and that is we do talk about politicians interfering with change and whatever. And if I could just talk about the clinical side, you have number of roles in life, but if I could just concentrate, the one on practitioner, the second one is a leader. When the translation of the hyperacute stroke test happens, the organization that you were working for did not get the designation, which I'm sure was quite a painful thing. But you, in many ways, exercised the leadership and involving and changing the whole thing in London. How do we make many other clinicians behave like you and look at the patients in the centre? Because that is one of the obstacles I've recognised in change.
It was, as you say, extremely painful, and took some time to come to terms with. I don't know how you make other people behave in the same way. We made a decision that we would... The Trust's, Guy's and St Thomas's, actually was very constructive in terms of saying to us, we went to them to say, look, there's another group of patients who we could actually transform the lives of, the patients who are then being spread around the hospital, the complex neurorehabilitation patients who weren't being managed effectively, and we took that role on instead of providing the hyperacute care. I think that most clinicians in that sort of situation, I'm sure, would fight, as indeed I did for a while, to try and get people to change their minds. I think that most people actually, the experience in terms of change is that there is always resistance at the beginning. People then do come to terms with it, and you and I have lived in the health service for long enough to see all sorts of reconfigurations that we felt upset about the merger of Guy's and St Thomas's, whatever it might be. But you learn to live with it. Time passes, and actually you realise, and it was very obvious for stroke very quickly, that actually the patients were benefiting in the end, and it became very hard then to argue that the changes that had been made were wrong.
Well, thank you for that. Thank you for your leadership. And as said earlier, you know, this is not just the beacon of innovation and reform in the National Health Service, but it's become the one talked about globally, which is fantastic. That is where the Mayor wants to see London, you know, as the discussion point globally. So we may come back and seek some of your thoughts and some of the challenges in other areas, and you never know, you might even switch disciplines. So thank you again, Tony.
Thank you.
Thanks.